they will start to develop a fear of weight gain. So much so that if they were to eat things that they thought might increase their weight, they would feel extremely guilty. This leads to avoidance of eating certain foods, periods of serious restriction, perhaps calorie counting, increased exercise, or other ways to get rid of food. When a person starts to develop these behaviours and these patterns of thinking, what we know that they can start to develop psychological symptoms. The intense guilt and anxiety creates a lot of distress, perhaps changes in emotional well-being. It can also impact on physical health, not always, but sometimes. And alongside this, these serious behaviours can affect social functioning, education, or even managing to carry out work. At this stage, what we see with these constellation of symptoms and behaviours that someone we would say has developed an eating disorder. And as you can see, I'm not talking about a weight. It's not characterised by weight, but it's characterised by a number of symptoms, of psychological symptoms and behaviours. And an eating disorder is a serious mental illness. Next slide, please. So just quickly run through, I know Jackie also mentioned a bit about the prevalence of eating disorders, but there's been a significant rise in the number of people in the UK with eating disorders over the last 8 years, and it's been particularly high in children and young people. So much so that the data from NHS Digital showed that when they screened the population in 2017, there has been an increase from 0.8% in 2017 to 12.5% of 17 to 19-year-olds who have developed an eating disorder. And again, in the 11 to 16-year-old category, a rise from 0.5% in 2017 to 2.6% in 2023. We also know that eating disorders are 4 times more common in girls, and they're not confined to any socio-economic or cultural group, despite what has been thought historically. We know in 2023, Jackie mentioned the number of people with eating disorders. We know that 424,000 children and young and adolescents in the UK were believed to be affected by an eating disorder. Next slide, please. So what is happening in our area, in London or in the catchment area that you live in, which is probably local to the Royal Free? There has been an increase in prevalence. This increase in prevalence is reflected in the number of referrals that are now coming to our service for an eating disorder, and this is across the whole of the country as well. Referrals to our service and to many of the services have really increased since the pandemic, and in our service it's tripled over that period since 2022-2021, and it still remains high. We've seen a 70% increase in referrals to our service since 2019. We also see an increase in admissions of children and young people with eating disorders to acute paediatric wards across England. And these are children whose eating disorders are of such severity that they warrant support and treatment in hospital. A particular concern has been the increase in children aged 12 and under to our service, which is something that is relatively new to us. Next slide, please. So, as I said earlier, eating disorders are incredibly serious illnesses. Anorexia itself has the highest mortality of all psychiatric disorders. It's the mortality rate of someone with anorexia nervosa is higher than that of someone with asthma or type 1 diabetes. We also know that patients with any type of eating disorder have a mortality rate twice the general population, and anorexia nervosa is 5 times higher. We know that the cause of death in 50% of patients with anorexia nervosa is suicide. And we also know that eating disorders last a long time. Overall, across the lifespan, the average length of an eating disorder is 5 to 7 years. But we'll explain within our service, it is much shorter than that. Next slide, please. So because we work within a child and adolescent service, we're going to particularly focus on young people and adolescents. What are the specific risks to adolescents with eating disorders? Adolescence, as you know, is a time of rapid psychological, emotional, and physical growth and development. And so any sort of change to nutrition and eating patterns can have a real impact on the physical health of a young person. And physical complications can be extremely serious. Affects growth and development. Huge impact. Eating disorders have a huge impact on educational and social development because they happen at a time when so much change happens that an eating disorder can impact whether the young person can get to school, whether they can concentrate, whether they can engage with their friends and family. Unfortunately, many young people with eating disorders often have another mental illness alongside, which makes treatment more complicated. There's also a very high burden on families and carers to support their young person, especially when perhaps they have to work, they have to look after other children or family members. Recovery can take a long time, and there's a high risk of relapse. So there's significant risks to a young person with eating disorder. Next slide, please. People often ask parents that come to us, what causes an eating disorder? I think what we know from the evidence and research that really eating disorders are very, very complex. And often it's quite a complex mix of genetics, genes, some form of biology, the environment, and also how someone thinks and personality factors. We find it impossible to suggest that there's ever one thing, one person, one situation, or one circumstance that causes an eating disorder. And so we will always be clear that there is no one thing or person that is to blame when this happens. Parents often feel extremely guilty. It is too complex an illness to suggest that one thing has happened. But we do know that some young people are far more vulnerable to developing an eating disorder. If, unfortunately, there's a family history of having an eating disorder, the risk is higher in a young person. And that is a combination perhaps of genetic effects, but also environmental effects. If they have another mental health difficulty, quite often we see young people with depression, anxiety, OCD. We also know that some people, young people that have a particular thinking style, that they are what we call perfectionists. They need to do their best at everything and feel a sense of loss of self-esteem and confidence if they don't do their best, or they're obsessive. These personality traits make some people more vulnerable to developing an eating disorder. We also know that having an autism spectrum condition increases the risk of having an eating disorder. Next slide, please. We treat a range of eating disorders. I've just done a pie chart that just shows that all the different eating disorders we treat. Most commonest for us in the under 18 age group is anorexia nervosa, or something we call OSFED, which is a sort of just sub-threshold eating disorder. We also treat ARFID, binge eating disorder, disordered eating, and bulimia. Next slide, please. So I've touched a bit on the symptoms of an eating disorder. And I would say the number one symptom of an eating disorder is the psychological impact of the illness, the impact on emotional well-being, distress that is caused by the illness, as well as physical symptoms. We've also explained that family life, social life, and education are really greatly affected. Next slide, please. As we see from these symptoms, which are all quite interrelated, serious eating disorders are serious mental illnesses, and they can be extremely hard to treat. You have to consider the physical aspect of treatment, because young people often present with acute physical risk. They're at risk of becoming extremely unwell physically, but there's also the long-term risk to growth and development. Having to treat a coexisting psychiatric disorder is very important. They're often common. And so alongside treating the illness of an eating disorder, other psychiatric illnesses need to be treated. A young person does not come on their own with an illness. There's often some complicated external influences that are affecting them. There may be difficulties at school with trauma and bullying, family bereavements, family separation and difficulties, all which fall into the mix of making it harder for a young person to think about their illness. We also know that patients often do not want to get well. And it is an illness where perhaps holding on to some of the symptoms becomes so important that the need to evaluate themselves in terms of their shape and weight becomes more important than their physical health, the impact on their education, the impact on their social life. And so, unlike many other illnesses, it's something sometimes they don't want to give up. Next slide, please. This is a very quick slide just to show that anorexia nervosa can affect the whole body. It can affect the brain, where the difficulties with concentration affect the mood, affect memory. It can affect any of the internal organs, but particularly serious is the heart, affect the kidneys, gut, bowel, and also obviously hormones are affected, which lead to period stopping, bone loss, problems with growth. And often also important for a young person is quite often their external appearance is affected. They become unwell, they lose their hair, skin becomes dry and unhealthy. Next slide, please. Just to give you an idea, I've talked about how eating disorders often are common with other mental health illnesses, disorders. And you can see this is a slide which just shows anorexia and bulimia nervosa and this OSFED diagnosis right in the middle. But quite often we commonly see a whole range of other mental health problems. The most commonest being autism spectrum condition, but we also see anxiety disorders, affective or mood disorders, ADHD, OCD, and a whole other range. Next slide, please. So I'm just going to talk to you a little bit about our service, where we are, who we treat. So we are a community outpatient service which treats children and young people under the age of 18 with a suspected eating disorder. We're actually based in a place called Queen Mary's House, which is a building about a mile up the hill from the Royal Free. And we have a ground floor area there. And we accept referrals from GPs from 5 boroughs in north central London, which include Barnet, Camden, Enfield, Haringey, and Islington. Next slide, please. Our team consists of what we call a multidisciplinary team. So we have a wide number of different disciplines and professionals working together so that we can treat young people in the best way we think we can. These include specialist nurses, dietitians, psychologists, family therapists, paediatricians, psychiatrists, psychotherapists, and therapeutic care workers. It's about 25 to 30 members of staff. And in our department at Queen Mary's House, this group of clinicians work as an outpatient service, but within our outpatient service, we have what's called an intensive service. We call it Eating Disorder Intensive Service, or EDIS, which offers enhanced support to young people who are particularly unwell with an eating disorder, and I'll speak about that in a minute. Next slide, please. So I think I've sort of touched on what we treat, but yes, most commonly referred anorexia nervosa, bulimia nervosa, or some form of sub-threshold eating disorder, which we call OSFED. We're getting more and more referrals with ARFID and also binge eating disorder. Next slide, please. In terms of our pathway, I think you might find it reassuring to know that when we get a referral from a GP or a CAMHS clinician or any professional working with children, the referral gets sent in to our eating disorder mailbox, and it is looked at on the first working day that it's received. And we have a duty clinician who will read that referral and contact the family so that they can do what we call a triage. The purpose of the triage is to get do a short risk assessment to decide how urgent treatment is, if treatment is needed, and how urgent it is. And according to need, we will treat any patient that's referral that's classified as urgent within 7 days, any one routine within 28 days, and any emergency referrals get seen within 24 hours. And when we say within 7 days or 28 days, we do an assessment and start treatment on that day that we first meet the family. So we do not have a waiting list to start treatment. Some young people will require more than what's happening in our community eating disorder team. Occasionally, some patients will need a short paediatric ward admission, and we're really fortunate here at the Royal Free because the eating disorder service sits within child health, and we work very closely with paediatricians so that we get the support we need when patients are at risk of being physically unwell. Some patients require intensive treatment, which again sits within our team, and they get the option of being treated every day. We offer evidence-based treatments in outpatients, and occasionally some patients need less than 5% to go into a specialist eating disorder unit or general adolescent unit. Next slide, please. Intensive service model. So the intensive service model was set up some years ago. It's very innovative in that we were seeing a lot of young people going into specialist eating disorder units, spending a long time in hospital, maybe up to 6 months, and then being discharged and relapsing. So this is a way of trying to offer treatment in a more intensive way to prevent hospital admissions, but also if someone does need an admission to the paediatric ward or a specialist unit, just to shorten those admissions. We're all within the same team, so a patient might see me, step up into intensive treatment, and then step back into outpatients. We focus on family-centered treatment, so it's supporting the family, and Jenny will speak about that in a minute. It's personalised so that we meet each young person's needs in an individual basis. And as I said, we've got a multidisciplinary team that works across outpatients, intensive service, and we go on to the acute paediatric ward if needed. Next slide, please. Over to you, Jenny.
Thanks, Vic. Okay, so I'm just going to say a little bit more about how we treat somebody with an eating disorder. So all of the treatments that we use are evidence-based treatments. We follow national guidelines, and so these will be the same treatments that any young person in England will experience. Okay, and as Vic said, there are no waiting lists for treatment, and that's because we work incredibly hard to ensure that we prioritise seeing our referrals as soon as possible. We also know, and the evidence shows, that early intervention reduces the length of treatment and improves recovery rates. So the sooner we can restore eating and physical stability, okay, the sooner we can do that, the better the prognosis. So Vic's already described how we triage our referrals as soon as we receive them, and for us, for over 90% of all our referrals, urgent treatment will start with us within 7 days of receiving that referral. And if someone is deemed as routine, we will start treatment with them within 28 days. On average, the wait is about 2 weeks. Okay, and so I think it's important to stress that, because I know following the pandemic, there's concerns about waiting lists for accessing mental health treatment for young people. But it's important to know that for our eating disorder service, that's not the case. The average length of treatment with us is less than a year. And admissions to specialist eating disorder units from our service are low and under 5% of the total number of patients that we treat. Next slide, please. So the evidence-based treatment that we follow is essentially around working with the family. So with all of our eating disorder treatments, we always work with the family. So we follow, for example, when we're treating anorexia, something called FTAN, which stands for Family Therapy Anorexia, or FTBN, Family Therapy Bulimia, which is essentially, we are treating the child with the family. It is not treatment of the family. That's a really important distinction. So we do not bring the family in to observe or look for blame or pathologise. Essentially, we recognise that the family join with us around the young person to support their recovery. They're seen as a resource, a very powerful resource to help them get better. Because we know that the evidence shows recovery happens for these young people within the safe base of their family system, when they receive high levels of very vigilant care and nurture every day. And of course, treatment means that they need support every day, all day, in various ways. So we work very, very closely with parents in this very difficult time for them to help them to re-establish responsibility for appropriate feeding and eating, which often at the stage we meet them has, as diminished or perhaps broken down. We help them to manage careful boundaries, support the distress of their child, and also, really importantly, help their child stay focused on their goals and what their life will be without the eating disorder. So it's a really, really big role that a family has, and that underpins all of our work. The priorities in treatment, one might think that actually, well, if we give them lots of psychological therapy, help with those distressing, difficult thoughts, then they will be able to eat. But unfortunately, it doesn't work that way round. We have to and do prioritise physical stability first, through either restoring weight if they've got a weight-losing eating disorder, okay, and regular eating. Vic's already shown on that slide the impact that an eating disorder can have physically, and you will see that it physically can be very, very dangerous. But also, if you have a weight-losing eating disorder, the body and the brain will have an effect from the starvation. We call it the starvation effect, where essentially, when the body knows that it's in a state of famine, the brain will do its job and it will prioritise seeking food. However, this is an illness that at the same time is telling that young person to avoid food. Okay, so you have this double situation of seeking and needing it, but also believing that it's dangerous and harmful. And within that, for that particular cohort of eating disorders, there is a huge internal conflict and distress. So by creating physical stability first, we can then lessen the impact of the starvation effect for anorexia, but also it will help with all eating disorders, just improve their psychological functioning. It will help improve their emotional stability when their body kind of comes out of that physical risk, and that grows their capacity to change. Now, it's not all about just eating, because it's a very serious psychological illness. So it's a very, very therapeutic approach, and we use additional therapies and specialisms along the way as needed and at the right time for that young person. Next slide, please. So essentially, in a nutshell, what we're trying to do is to help these young people face their fears every day, to grow their life beyond an eating disorder and overcome the anxiety such that they make this eating disorder redundant and no longer necessary in their lives. I'm going to hand over to Lindsay now, who's going to take you through a patient case study.
Thank you. Yeah, I'm going to talk about a real life case study that's been within our service. The name of the young person has been changed, obviously, to maintain their confidentiality, but it will hopefully bring some of what Vic and Jenny have said to light. Next slide, please. So this is Millie. So Millie was 12 years old when she came to our service and was referred by her GP. She lives with her parents and some siblings, and she was at school at the time of her referral. The main concerns raised at assessment were her low body weight, and she was actively losing weight at the time. And there was a lot of distress around meals and food choices. To the point where she would only eat the food that was prepared by herself. She wasn't eating kind of the family meals or the things that her parents would prepare for her. Next slide, please. So, like I said, there was huge distress. The thing that was really striking was not only the distress at meal times, but also the distress that she was expressing even during the assessment. Parents found it incredibly difficult to talk freely about their worries about Millie, because she, her anxiety was so high about letting other people in. She was, expressed a lot of anger and frustration towards her parents, and at first was denying this kind of want to lose weight. She had significant deterioration the month before her referral. There were signs and symptoms of anxiety a lot at school. She was struggling to sit down in class. She was refusing to sit down, which we then later saw lots of, but that was very present at school. And yeah, as I said, lots of conflict at home, and there was some kind of risky incidents arising and increasing. Both parents, who were very, very active in her treatment and crucial, but were really, really struggling at the time of referral, and were struggling even to talk freely because, like I said, Millie was not allowing them to do so, and had high distress when her parents were kind of giving us the information about her eating. Parents had witnessed a history of reduced eating and concerns for about 6 months before they came to us, and that triggered the referral to us. Next slide, please. Parents believe that this had started or was triggered around a time of a healthy eating talk at school, where they talked about kind of good and bad foods, or healthy and unhealthy foods, and that kind of triggered quite an obsession for Millie. She had low body weight in relation to her peers and her height and her weight and her gender. So we measure people's physical status around their weight for height. We use something called weight for height, and she had a very low kind of the equivalent of BMI for kind of young people that we use, and she had a very low weight for height. Although, like I said, at the time she was denying any kind of worries about food, and she denied any kind of physical symptoms, even though we suspected that she probably was experiencing more than she was letting on. As Vic had demonstrated earlier in the presentation, obviously with that low weight and with the amount that she was restricting, it was obviously highly likely that she was experiencing quite a lot of physical symptoms, but she just wasn't letting us in to kind of know about those things at that time. She when seen alone, it was very visible how anxious she was. Like I said, she was refusing to sit down, which had been happening at school, but translated to our clinic, it took a long time before she did. So during appointments would stand up in the room, very kind of guarded in what she wanted to talk to us about, but very obviously anxious. She had a real fear about being admitted to hospital. She really didn't want that. And she was able to tell us that she had some anxieties about food, but she wasn't sure why. But she denied any weight and shape concerns at that time too. Next slide, please. So at assessment, so that's the point where she came in after the referral, like Vic and Jenny said, she referral came in, screened by our duty clinician, and was triaged, put into an assessment. That was the assessment that I've just described, and she was given a diagnosis at that assessment of anorexia nervosa, and a slide here demonstrates why, because she had all these things were present. Yeah, I think that's fine. Next slide, please. So as Vic said, the assessment starts treatment in our service, so there's no waiting lists. You don't get put onto a further waiting list sheet. Treatment started at assessment. So at that assessment, she would have been given some, as well as asked a lot of questions about what was going on, also given a lot of information. So provided with a meal plan and some meal guidance around, based on the food that she told us and the family told us she was eating, and then some guidance around where they needed to increase that, and we have standardized meal plans and things that we use, but obviously also hearing their story, kind of tweaking that to their situation. So we also have a psychoeducation group called our family support package, which is offered to every parent coming into the service. So that is run by one of our family therapists, but also contributed by several disciplines, I think, within the team, and that's on offer for all parents. It's a 4-week programme to give people basic kind of psychoeducation that supplements the work that they would be doing with their clinician. So as Jenny said, the different types of treatment, obviously she was diagnosed with anorexia, so she was put in kind of the treatment model that she would have been treated under was FTAN, so family therapy for anorexia. And as said earlier in the presentation, the focus at the start would have been primarily on her physical health, because she was extremely low weight when she came to us, and it was very obvious she wasn't eating enough. Physical health monitoring was initiated at assessment, so she would have had her physical health measurements taken at assessment in order to provide a baseline to keep measuring that with every appointment that she came, so that we knew what we were doing and how effective that was being on her treating her physical health. And the team liaised with her school pretty quickly within starting with us, because obviously we heard during the assessment how school had noticed so many things, and she was obviously expressing a huge amount of anxiety at school. So that was a priority for the team, was to also liaise with the school about thinking about shorter days and adjustments that she needed within her school day. Thank you. Okay, so what happened next? So, I mean, all of that would have all happened within the initial assessment, which is just a good illustration of what Jenny and Vic has said, is that treatment really does start on the first appointment. It's not that you kind of gather all the information then put on a wait list. It really it's a long first appointment, but it's the reason for it is because we want to gather the right information and then tailor the treatment for the family that we've got in front of us. So what happened next was she came within our service. She was within an outpatient, within the outpatient branch of our kind of service to begin with, and the clinicians allocated, along with her consultant, would have, you know, focused primarily on the food and the restoration of her physical health. So thinking about the food, thinking about the meal plans, while also getting to know them as a family. So hearing more about the distress that was happening and making further assessment about what was happening. All of these are kind of happening in conjunction with each other, obviously. It was really, really tough for Millie at the start, and is often for many young people that come into our service. Obviously, you know, they've got this illness, and for Millie, she'd probably been suffering with it for some months, and so coming into our service and then having to face the fear of needing to eat more, that was a really, really tough time. And she became too unwell to attend school at all. So you heard at the beginning she had started off with shorter days, and then it became apparent that actually she wasn't really safe enough to go to school at all, so that was paused. She had a couple of attendances to A&E due to the level of distress. So you can see again from what Jenny was saying is the family, they've got a really tough task on their hands. They get given this kind of information, they get given a meal plan to start with, and this young person goes from eating maybe very little to having to kind of eat a full meal plan, and the family are then, you know, in a position where they're having to manage the kind of distress that comes with that. And Millie, there was huge distress that came with that. So the family, rightly so, took her to A&E for further guidance and had concern about her risk at several times. She had a weight loss at the start, which again is quite common within our patient group, due to the need to kind of eat more, and that being really, really scary and anxiety provoking. Next slide, please. So she moved from, well, I say moved, it's not really a move, it's an add-on, is she moved into the intensive service. Now, the intensive service, again, we're all part of the same team within the eating disorder service. So the eating disorder intensive service kind of supplements the and bolts on to the additional FTAN work that's happening. So she moved, the intensive service became involved, and she came in and had an initial assessment with the intensive service, and I was present during that, and I have a huge amount of confidence in our intensive service. But I must say, with Millie in particular, she was very acutely unwell, and I had thoughts of whether, you know, there was conversations previously to this, and I had thoughts within the assessment, and we had open conversations with Millie and her parents about actually it was, you know, there was a high chance that hospital admission might be needed for her, given her level of acute kind of risk, low weight, high distress. Now I'm pleased to say that didn't have to happen. With, you know, the intense package was huge support to parents. In the intensive service, we offer a lot more practical support that supplements the kind of consultation and psychological support that's going on. So there was a lot of practical coaching around meals, bringing parents in, coaching them on how to do it, coaching them on what portion food to provide. A key part in Millie's treatment that was really, really vital, it was the individual sessions that she had. So she had some key workers allocated, and they got to know Millie on a different kind of level, I guess, to what we had before. So worked with her and were very patient with bringing her into the room, gradually kind of getting her to sit down on chairs, which had been a real struggle for her. She was started on medication, which again felt like a huge turning point. I think she had been quite reluctant up to that point, so starting medication was a really good turning point for her. And obviously we continued the physical health monitoring, and the boundary setting was part of the coaching that we did with the meals. Next slide, please. So here you can see the progress that she made, and like I said, I'm pleased to say actually she avoided a tier 4 admission, which is one of the reasons I wanted to use Millie's story, because she was someone that came into our service and could well have gone straight to tier 4 if she was in another service, in my belief, if she didn't have the intense, and the family didn't have the intense work that they had. So she and her family worked incredibly hard with the team and the service, and engaged in the programme. And one distinct memory that I have with Millie and her family was that at the start, Millie really wanted to go on this particular holiday. And I will be honest, I sat there in that initial assessment and I thought there is very little chance that she's going on this holiday, just from what I saw at the start. And I'm pleased to hold up my hands and say I was absolutely wrong, because she and her family worked incredibly hard. And they, in the last session in the intensive service, they were going on the holiday the next day, because she and the family were in this place that they could do that. And it was emotional for them, but I think, you know, a real moment for us as a team as well, to really acknowledge the work that the family had done, and the work that we could help them with. So that was really nice. So she stepped out of the intensive service, they went on their trip, which I believe was a huge success, and had a good time, and they came back and continued in outpatient care. Slide, please. This is just an illustration of her weight for height chart. Obviously not the only marker of success, but this is a good illustration of, again, what's been said about physical health and the need to restore the weight. So she came, the lower line at the bottom is this 80% weight for height mark. We would look to get someone to kind of 90-95%, and as you can see, Millie's weight progress, there's a slight dip at the beginning, which, like I said, is really common when someone's starting treatment, because it's a really kind of intense start and really tough, because they have to face their fear. But actually, obviously, we want them to get onto a weight gaining trajectory, and therefore as Millie and her family, like I said, worked incredibly hard, they started to make regular progress, which is demonstrated there. Yeah, I have said this already, really, so I won't repeat, but yeah, she's went on this trip, which was amazing. She returned, she's been in she continued care in outpatients, and actually continued to work with the team, and she's actually now since been discharged from the service entirely, including the outpatient service, and that is all due to her and her family's hard work and commitment to the treatment with the team. So that's really nice. So yeah, just some reflections for you all. I'm aware we're going to go to questions. So just to reiterate some of the things that Vic and Jenny have said, that none of there was no cause for Millie's eating disorder. Of course, there were things that contributed to some thoughts around what might have triggered it, but there was no one single cause. It could have been caused by a manner of things, as stated earlier in the presentation. Absolutely no one was to blame in any of what happened to Millie. She was someone that illustrated that low weight and that starvation effect that Jenny talked about is, you know, it was absolutely in play with Millie. She was very low weight, very malnourished, and had that kind of starvation effect, so the increase of distress. And when she gained the weight, those things were massively reduced. Parents were absolutely vital in her recovery, and still are, obviously, doing the work, I'm sure. And yeah, keeping in touch with real life. So having those motivations around holiday, getting back to school, all of those things were key things for Millie. She needed, we work with goals and motivations, and they were very much part of Millie's care, to keep focused on what she wanted to get back to. Thank you. Thank you. Hand back to Vic, I think, who's doing this.
Hi, thanks so much. I'm just going to put the question and answers on. Can I just check with George, do we start off with the questions you've already sent me, or do we go to the ones?
If we could start with the advanced ones, and then we'll open it up to the attendees.
Okay, so we started, the questions we have been sent a few questions in advance, and one of the questions we've asked is, does your service treat young adults, i.e. over 18s? If not, what happens to your patients once they reach this age? So no, we only treat up to 18. But if a young person needs specialist treatment beyond the age of 18, and that treatment because they haven't recovered from the eating disorder, we refer to the adult eating disorder service, which is at St Anne's in North London. And usually we would make that referral quite some months before they reach 18, so that we meet the team, we work with them, they get to understand the patient's needs, and we help with the transition. Occasionally, if we can see that a young person is really doing well and their 18th birthday comes and they haven't quite recovered, we will continue treating them for a short period of time. Second question is a really interesting question. Are you using any virtual reality or other digital tools to rehearse real-world situations such as eating out or managing social pressures around food? I don't know if my colleagues want to say anything about this, but we don't actually. And I know that there is some research and some evidence that they can be used with eating disorders. I know that other mental health conditions are using digital tools to rehearse real world situations. I would be very interested to use some of these, but we haven't actually started using that, and would be open to thinking about that as well.
I would say that as part of our treatment, we are thinking about how we help young people to get back to eating at school and eating in social situations. And a lot of overcoming the anxiety is to not avoid these things. So they get a lot of support and step-by-step coaching to actually manage to eat that meal in school or have their first meal out in a restaurant with their family again. So really breaking that down is important, but we're not using any virtual reality tools with that. We're
not at the moment.
Putting them out there to do it.
Third question, have any protective or preventative factors been identified which reduce the likelihood of developing an eating disorder? I mean, we know that there are a lot of protective factors which can help someone build the resilience to protecting them from eating disorder. We know that sort of individual factors like building self-esteem, being able to manage emotional distress, media literacy, being able to read social media properly and not be too sort of manipulated by images, having a positive body image about oneself, thinking that they appreciate themselves for what they are inside, not externally, and having problem solving skills. We also know that there's some family protective factors. One of the things we always say is regular family meals, parents and families role modeling, normal eating, dinners together, having a positive family environment in the family, not having a focus on appearance or talking about one's own appearance or diet, but sort of like thinking about having positive communication, but also clear boundaries so that you develop a sense of security for that child. And modelling basically healthy behaviours. So those are all sort of like family protectors. And then there's obviously society's way of developing protective factors. So we know that societies that accept body diversity perhaps have a lower incidence of eating disorders, but also having sort of structures for young people to offer peer support, social groups, and also limiting sort of weight-focused environments. So those are sort of the protective factors. In terms of prevention program, I mean, I know in schools there are some very good prevention programs in schools, thinking about peer support groups, building self-confidence, thinking about body positivity. We also know that eating disorders, if there's some high-risk groups or people that are more vulnerable to them, we can reduce the risk of eating disorders by having certain CBT type groups. Don't know if you want to add anything to that. What was the other question we had? Could excessive exposure to food-themed games or videos influence a child's brain to eat less real food? It's a really interesting question. I actually had a look at the evidence base when I saw that question, And I think that's right. I think that there is some evidence that exposure to digital food images or videos which show highly sort of saturated, palatable food images might help people think that that's the type of food they prefer. And so there is quite a bit of research on that. So yes, I would say to that. So I'm racing through these questions. I know we don't have much time. There is a question about, the other one we had was, if humans evolved with natural cycles of hunger and scarcity, why is this viewed as a problem in today's world? Well, I suppose I'm hoping that by our presentation we show that an eating disorder is a mental illness very separate from the sort of natural cycles that unfortunately some human beings going through in terms of famine and hunger. You know, it is a group, it's the eating disorders grouped by serious concern, thoughts, feelings, behaviours that affect psychological health and physical health. And the reason that these symptoms become a problem is that they may cause a risk to physical health, or they impact on emotional well-being and social and educational functioning. Okay, so going through some of the questions, we just got few more minutes, is that right, George? What medication is used? Yes, so do you want me to answer that? And then I'm hoping you're going to be able to answer some of these questions. So using a medication isn't the sort of first resort when we treat a child and adolescent. It's usually, I would treat medication if I thought there was such significant risk to that young person that they were likely to need to go into hospital, or their physical risk, despite the treatment they're getting through the evidence-based treatments of family therapy, it isn't quite enough. It's like an additional tool in the toolbox. And so it depends on the type of eating disorder, but the type of medications that are used in young people are quite limited. And I have to say that the research and evidence-based isn't very good in young people because there hasn't been research, but from clinical experience and what practices in this country, with some eating disorders, we'd use some form of antidepressants or SSRIs, and sometimes we use medication for very low weight patients who are extremely unwell and a lot of distress. Is an anxiety medication, which is called an atypical antipsychotic at very low doses. What is the biggest challenge your team is facing at the moment, and are there any plans to grow and improve the service?
I don't know.
Yes, please do that.
I think, to be fair, going through the pandemic with the huge surge of referrals we had in eating disorders was an enormous challenge, but that enabled us to really develop our ways of working, and we were able to really transform the way we work during that time, and we were eventually fortunate enough that we could grow the service. But where we are now, we have very recently been able to develop our work with ARFID, and one of the areas that we're looking at improving our work with is where there's neurodiversity, because many of our young people may come to us, they may have a diagnosis, but they may not. So it's understanding how we work with different kinds of thinkers to help them to recover. So that can be a real challenge for neurodiverse people. I think a challenge we would have, and many services would think about, is how accessible we are to all areas of the population. Not just physically, but we know that mental illness, eating disorders, have different meanings in different families and cultures. And so sometimes it can take a long time for people to recognise it's an issue and to understand that it can be helped. So that's something we're always mindful of, is how we can be as accessible as possible to the quite a large population really that we serve. Anything else we would add?
Yeah, I'm just wondering whether we should just squeeze in the last question there. Do we have time? Oh, there's a few more. Have you noticed any changes in the types of cases you're seeing, especially since the COVID-19 pandemic? I'll just do highlights and you can add. We're seeing younger patients.
Yeah.
We've really seen a real increase in under 13s presenting with serious eating disorders. We are also seeing, I suppose it's called avoidant restricted food intake disorder, which is a type of eating disorder which is caused by perhaps different, it's quite a complex illness, but it may affect growth and development. We're seeing many more young people being referred with ARFID. Anything else you want to say about?
No, I think that's really kind of making us really think about our treatment and understanding more about the factors at play with what gets in the way of someone being able to have a healthy relationship with food. So
didn't see Enfield or Haringey on the list of boroughs. Yes, they were on the list. We do treat patients from Camden, Islington, Barnet, Enfield and Haringey. I assume the vast majority of patients need to be accompanied by a parent. Is this a barrier to treatment given the location of the service, journey time of work, school, possibility of treatment at other centres, co-management GP? I mean, that is a really good point. And I've just thinking, so I've seen patients from Enfield that have very long journeys just this week. And depending on the age, but most young people certainly at the beginning of treatment need to come with their families. We do try and adapt treatment to do virtual online type appointments, which can be really, really helpful. Occasionally, I suppose, Lindsay, you went to a satellite hospital day today to see a young person it was in Enfield, is that right?
Yeah, North Middlesex, yeah.
Yeah, so we do, and occasionally we do outreach to the home if someone is extremely unwell, but it is challenging, and so we do try and reduce the number of sessions that parents have to, when they have to come. It is challenging. Yeah, I'm just thinking, I can see Jackie's got her hand up.
Thank you very much. I'm going to draw the discussion to the end, and that's because we are just about running to time. So I'd like to say a huge thank you to Victoria, Jenny and Lindsay on behalf of the Council of Governors and everyone who's joined us this evening. Thank you very much. We're truly grateful to you for taking the time to share your incredible work with us. Your service is playing such a key role in transforming lives. It's not only clinically outstanding, but is also rooted in dignity, empathy and respect. This event has been a powerful reminder that recovery is possible, and behind every statistic is a person whose journey deserves our full support. I'd also like to take a heartfelt thank you to everyone who's joined us this evening. Your engagement helps make events like this much more meaningful. I know that we didn't get to your questions during the Q&A, but please don't worry about that. You can get in touch with our membership office. Their email is on the screen now and is in the chat, and they will make sure that the answer is shared with you. If anyone experienced connection or visual problems during the event, a recording of the meeting will be shared on our website in the coming days and included in the next membership newsletter. This has been our final Medicine for Members event of 2025. We hope you've enjoyed this year's programme. If you've missed any of our previous events, recordings are available to watch on our website. We're always looking to improve these events, and your feedback is invaluable to us. Please do take a few minutes to complete our short survey about this evening's event. A link has been shared in the chat. And if you have thoughts about any of this year's events, our memberships office would love to hear from you. If you'd like to get in touch with our Council of Governors, you can do so by email, and details are on the screen now. Just before we finish, I'd like to invite you to join our annual members meeting on Wednesday, the 26th of November at 5:45 p.m, and that will be held at the Royal Free Hospital. We will be reflecting on the achievements and challenges of the past year and celebrating the dedication of our incredible staff. It's a free event and we will provide refreshments. You can find all the details on our website, and the RSVP link has been shared in your chats. So once again, thank you very much for being with us this evening. We hope you have a lovely rest of your night, and we look forward to welcoming you again soon. Thank you. Good night.
Nice, thank you.